Hello, my name is Goubran and I'm presenting our work on the use of bracing in early onset scoliosis at the Royal Devon and Exeter Hospital. The scoliosis is classified in a number of different ways, including age and etiology. However, what we've done is we've decided to classify early onset scoliosis in this cohort as any children presenting with this under the age of 10 years. The aims of our study in this early stage are to hopefully delineate subgroups at risk of failure of treatment with bracing, but also to investigate the mean time to surgery, or what we would classify as failure of bracing treatment. With regards to our study, this is a historical cohort study. All of these children have been conservatively managed for their scoliosis treatment. Our cases have been identified and data analysed from our electronic system, and the radiological data has been analysed through our PAC system. As I mentioned earlier, the inclusion criteria were children that presented with scoliosis under the age of 10 years. Our exposures, as I also mentioned, would be basic etiological data and demographical data for the children, as well as Cobb angles. And the failure, or our final outcome, would be time for decision for surgery, which we would consider failure of bracing treatment. The decision was made quite early to analyse our time to event analysis using Kaplan-Meier. We stratified our data by gender, age, and the Cobb angle at the time of diagnosis. And these Cobb angles were taken by two of the authors for inter-observer reliability purposes. In terms of our results, after exclusions, we analysed the data of 59 patients, and the mean follow-up time for that cohort was just under 3 years. This is our Kaplan-Meier curve that covers overall the survivorship of the patient cohort. And as you can see, this includes our 95% confidence interval and survival estimate. In terms of those results, the mean age at presentation of diagnosis was just over 5. 12 of the patients were then listed for surgery subsequently. The mean time to failure was just under 4 years, and this happened with an average age at approximately 7. With our analysis and discussion, it's become very apparent that analysing longitudinal data, the likes of which we are doing, is nuanced and complex. It's very difficult to perform stratified analysis due to these small numbers, and the series needs to be expanded and continued over a longer period of time. As you can see, there has been examination and investigation into the use of bracing in juvenile idiopathic scoliosis, but this would be and will be the largest series that we're aware of for what we would consider early onset scoliosis, and I think this would provide a baseline for future international and UK studies. What this introduction and study has done for us is absolutely define what we need to do in the future, which considers expanding this series as best we can, prospectively analysing our data, monitoring patient-reported outcomes independently, and as well as doing a proper systematic review of the current evidence underway. There are, however, limitations, and we've covered most of those, but these will be the size of the cohorts, the amount of time we've followed them up. It's probably unethical to expect us to have any kind of comparator in this sort of study, which makes analysis even more challenging. But this is a single centre, and these are low numbers. The plans for a multi-centre bracing trial have begun, and this will be led by a cohort in Sheffield in the coming 2 to 3 years, and this will be invaluable for us to be a part of as well. So what are the conclusions we can draw? Well, it is limited, but bracing appears to delay surgery certainly by 4 years, and obviously this has its own benefits when considering scoliosis surgery. Future studies will allow a comparison of survival outcomes between both the subgroups and a collection of patient-reported outcomes, which will be vital. Thank you very much for listening.